Hello, my name is Abby Roberts. I'm the clinical lead midwife on labour ward at Poole and the HDU maternity HDU lead. Today we're going to look at your airway and breathing station and just give you some simple tips as to how to manage ladies' breathing. First off, we're going to look at the simple steps that we could take before we need to use any oxygen that may be responsible for the lady having a low oxygen saturation. First off, obviously we're going to be looking at their position and whether or not the lady is obstructing her airway. If she's laying flat or she's got rather pendulous breasts, she may be obstructing her own airway. First would be to sit her up so that she can expand her lungs nicely and get a normal cycle of breathing so she can get a good breath in and a good breath out. Is she using her accessory muscles? Is she raising her shoulders in order to help support her breathing or not? Once we've established that those things are okay and that she is actually in a good position, able to expand her lungs herself, then we need to be thinking about ways to deliver oxygen to her. In order to show you how to do this, I'm going to talk Lisa through a few of the things that we may be using. So this poor lady may have breathing issues. She may be on remifentanil, so she may need some nasal specs, which we have, and I will show you how to apply. Nasal specs. So we can apply these, obviously attach them to the wall, oxygen supply, and we deliver it at a maximum of 2 litres. Apply it into the nose and around the ears and tighten it at the front. So it can't be, oops, thank you Lisa. It can't be whipped off the back of her head very easily. It's probably not that easy to see. Sometimes ladies tend to get a little sore around the ears with this or across the cheeks, and you can apply a piece of tape across underneath where it's going to be touching so that they have a limited amount of friction there and prevent any pressure sores. But it may be worth just checking that occasionally also. If you find that they need more than 2 litres and not maintaining their oxygen saturation, then we can look at giving oxygen via a Hudson mask, which is just a normal mask. So I will find it for you. Again, just a normal mask. It's not good for giving high flow oxygen. Doesn't give them a particularly high concentration of oxygen, but you can turn it up and sometimes that's useful. Best way to give them high flow oxygen would be to give them a non-rebreathe mask, which you should have available on all wards. This again can be attached up to the oxygen on the wall. Can be given at 15 litres, so you can whack it right up. In order to inflate the bag, press the little valve on the top. That inflates the bag. Once the bag is inflated, apply to the patient's face, and this can give up to 85% oxygen this way. It won't work if you don't inflate the bag first. One of the is they tend to get very dry, so you could also give humidified oxygen this way. Is it enough? Humidified oxygen can be given quite readily on the ward. Just need a bottle of sterile water, a connector for the wall, and some tubing, a normal Hudson mask, and some tubing. Attach them all together. So this connects onto the connector, and then if you open the sterile water,
just push down on the bottle to break it.
Place that in, screw that on. Oops, sorry. This is attached to your Hudson mask, and this gets attached to the wall oxygen supply. It's a screw-on fixture, so it just allows you to attach it directly to a wall supply. In order to do that, you probably need to remove the initial, I don't know if you can see this. So this is where your oxygen supply is normally. You need to remove that bit, which is where you attach your oxygen tubing.
Put that somewhere safer later.
And then screw this bottle on. If you do it the right way, it will attach. Anyway, there you go.
Okay. And if you just have, we'll just take that off a sec, and if you just have a look on there, it has got a dial at the top that says your percentage of oxygen and your numbers of litres that you need to give, so you can give the correct amount. So 28% oxygen has 5 litres of 5 litres set on the wall. You've got 35% oxygen, which is 6 litres, 40%, which is 9 litres, and 60%, which is 11 litres. Just to be aware, with COVID times, there was a prerequisite that they had a maximum of 5 litres oxygen at any one time on the ward, but actually there's new evidence suggesting that 60% oxygen is safe to give on the ward because it's not an airway generating procedures. Please just go back to your own trusts and see what is acceptable for your labour ward or your COVID area, and at what point they would need to transfer to a critical care environment.
The advantages of humidified oxygen, it's better for ladies who are having long-term oxygen therapy on the ward because it gets very drying. So the humidified oxygen can help with expectoration of any sputum on their chest particularly, but obviously it does take a bit of time to get all your bits and pieces together. You can also give nebulizers, which should be readily available in most trusts. It comes disconnected as such. So it comes with a mask with a nebulizer connection and the small nebulizer capsule. You unscrew the capsule and then add in your nebulizer solution into this little bit, reattach it, attach your mask onto the top and attach this one to your wall supply, and then just turn it on full until you get
no misting.
Misting, yes, that's the word. If you're using a very small amount, sort of about 1 ml that comes for the nebulizers, then just add in 5 ml of saline in with this as well. That will just help it humidify. Okay. The only other things we need to talk through are airway management. I'm sure you're all familiar with the Goodell. The Goodell airway that is measured from the lips to the angle of the jaw. This is a very large one for this little person, but it does fit if you're measured. However, this dummy unfortunately doesn't have the ability for us to pop one in to show you, but they are applied upside down, and then when you get resistance, turn them over and pop them in. Okay.
This is not necessarily for you to do that, but actually a Goodell is only tolerated by somebody who's very unconscious. So you know that their conscious levels are increasing when they start to spit out their Goodell airways. So it's more to be aware for you that that they are really quite traumatic for the patient. So you may be supporting that person once they've had a Goodell taken in, or put in, or taken out. It's not necessarily for you to do it.
Another type of airway, we have these nasopharyngeal airways, which are measured again from, they're measured from the midline of the nose to the tragus, which you probably can't see that well.
Wear your earrings.
Yeah. This one's rather large for this dummy, I'm afraid. They just have a little bit of lubrication and then pop them as if you're just. They've got like an angle on them, just as if, so you don't not scratching their nose, and just keep pushing, and then insert the airway, and then that can be followed up once it's put the mask on the top.
So while the NP airway, so the nasopharyngeal airway, looks worse, they're actually tolerated much better by patients. And in fact, you can sometimes see patients walking around the wards with them on, whereas the Goodell airway, they need to be really quite unconscious to be able to tolerate them. We probably wouldn't see that many in maternity, so our suggestion to you is to have a look at your crash trolley, see where these are located on your crash trolley, just so if you are asked to grab one in a hurry, the adrenaline doesn't take over and you can't find it or you don't know what it looks like.
And they're easily removed as well.
And for both of those, when you remove them, just have quite a lot of tissue, because there's normally quite a lot of flob is probably not the best word, but there is stuff all over them that is quite sticky and horrible.
The only other thing I wanted to talk to you about was a peak flow meter, which I'll hide this because it's been stolen. So the peak flow meter is just it's just a gauge for volume, that they can inspiration volume. If you set the counter to 0 and then you get the patient to take a deep breath in and just to blow in a big huff out, and it will measure as to where it is on the scale. Okay, it's just in case they're required. The mouthpiece is disposable but can be kept obviously for the patient to use again.
Peak flows, normally patients that require them normally know what their normal peak flow is, so you may be asked to do them pre-nebulizer and post-nebulizer, and it's a good way of assessing the effectiveness of the nebulizer in opening up their lungs, so they've got a good expiratory flow, so a good huff, and that's the blowing out that we said about. Okay, so the workstations wise, this is the airway and breathing one. Hopefully that's answered some of the questions on your quiz. The next one that you'll be logging into or viewing via YouTube on the Wessex Math Academy is the ECG one, and then there's a disability and exposure one as well. So it's following the ABCDE approach that we've been doing all day. And then once you've done the workstations, you'll be going back to the last lectures of the day. Thank you. Thanks, Abby.
God, that was awful, I'm so sorry.